It's the Brian Lehrer Show on WNYC. Good morning again, everyone. We'll call this segment, How Not to Die Like Lindsey Graham. Atherosclerosis, his reported underlying condition, is successfully managed in many people his age, which was 71, to prolong life and quality of life much longer than that. We don't know yet if Lindsey Graham avoided the kinds of screenings or treatments that can find and minimize that plaque buildup and prevent the aorta from bursting, as the medical examiner said happened to him. But because the underlying condition is so common, we thought we would do kind of a public service announcement segment so as many people as possible know how not to die like Lindsey Graham, or at least improve your odds. With us now, Dr. Adham Elmously, an attending surgeon in the section of adult cardiac surgery at New York Presbyterian, Columbia University Irving Medical Center. Dr. Elmously, thanks so much for some time today. Welcome to WNYC.
My pleasure. Thanks for having me.
What's an aorta?
So the aorta is like the big highway for blood flow in the body. It's the main artery coming out of the heart that gives blood flow to the entirety of the body. So as it leaves the heart, it first gives blood flow to the brain and the arms. And then as it goes down into the chest and belly, it gives blood flow to the liver, spleen, kidneys, and intestines. And then it continues down to give blood flow to the legs. So it literally supplies blood from the heart to the entirety of the body.
What's your understanding from the press reports of the medical examiner's statement of how Lindsey Graham died? They say aortic tear or dissection. What does that mean?
So I don't know the details of his case. Obviously, we're talking about this in the setting of somebody's death, which is heavy, but we can use it as an opportunity to maybe prevent this from happening in other people and help them understand how this works. So an aortic dissection is a tear in the wall of the aorta so that blood flow, rather than flowing in the actual lumen of the aorta, it flows in the layers of the wall. And that can separate the wall into its different components and thin it out. And the main complications that can happen from that are, number one, something called malperfusion, or a lack of blood flow to critical parts of the body. And number two, a thinning of the blood vessel to the point where it has a hole and ruptures. And that can cause really rapid blood loss into the chest and death. When there's malperfusion or a lack of appropriate blood flow, it can present in many different ways. If there's a lack of blood flow to the brain, people can have symptoms of a stroke. If there's a lack of blood flow to the heart, it can simulate a heart attack. And then if there's a lack of blood flow to the spine, people can have signs of paraplegia or leg weakness. And if there's a lack of blood flow to the intestine, people can have really severe abdominal pain. When a rupture happens, it can be contained or uncontained. A contained rupture means there's a hole and it leaked out, but there's some tissue that's preventing it from completely being wide open. And in that case, patients can still survive and make it to the hospital and get it fixed. If it's a free rupture, the blood can basically escape at a rate that's too rapid to be able to make it to the hospital and have surgery, and that can cause a very rapid death.
Listeners, we can take some heart health, most specifically aortic health questions for Dr. Adham Elmously, an attending surgeon in the section of adult cardiac surgery at New York Presbyterian, Columbia University Irving Medical Center, as we're trying to use the sudden death of Senator Lindsey Graham as a teaching moment to maybe help prevent some of you from meeting the same fate, or maybe your parents or your grandparents. 212-433 WNYC 212-433-9692. You can call or text with your question. Would I be right, Doctor, if I say that kind of gradual weakening of the aorta to the point where it could burst and cause sudden death is something that would typically be seen developing over a period of years with some basic screening techniques?
It depends on the cause. So most commonly we associate an aortic dissection with an aortic aneurysm or an abnormal dilation or enlargement of the aorta. And in most cases, patients who have a dissection or a rupture have a dilated aorta. Rarely, patients can have a dissection when the aorta is a normal size, and sometimes that can happen for reasons that we don't quite understand. But the main risk factors for an aortic dissection are things that can be controlled, but the screening part of it is tricky. So risk factors that can cause degeneration of the aortic wall to cause it to be weak are things like smoking, cholesterol, and high blood pressure, and those are the modifiable risk factors that you can avoid from developing. Other risk factors are sometimes genetic. So patients with what's called a bicuspid aortic valve, or an aortic valve that has 2 leaflets instead of 3, have a higher risk of a dissection. And people with connective tissue disorders, like things like Marfan syndrome or Loeys-Dietz syndrome or Ehlers-Danlos syndrome, these are typically people who can be tall and skinny or have hypermobility, flexible joints. Those people can have aortas that are more prone to dissection. And if you have one of those things that are known, then you definitely should get screened. Another reason to get screened is having a family member, especially a first-degree relative with a dissection. So if somebody comes in with a dissection and we fix it in the hospital, the first thing we want them to do when they go home in one piece is have all of their family members screened. But outside of that, we don't actually recommend screening for all comers. So if you don't have any risk factors, you don't have any family history or first-degree relatives like a mom or dad or son or sister with an aortic dissection, then there's no reason to be screened.
There's a test that many people get as they begin to age called a calcium score, which, as I understand it, measures plaque buildup in the arteries. Am I describing that right?
Yeah, so a calcium score is a form of a CT scan or a CAT scan, which is a type of cross-sectional imaging that gives detailed anatomy of the chest and the heart and the aorta. And that is used specifically, the calcium score is used specifically for looking at coronary artery disease, which can cause heart attacks. As kind of a side effect of having the calcium score, we can see the aorta and see if it's enlarged. And then if it's slightly abnormal or slightly enlarged, then we enroll people in a screening program. At Columbia, we have an aortic center where we have a screening program where patients who have aortas that are slightly enlarged get every 6-month or annual imaging so we can follow it and make sure they're in a safe range. Other imaging modalities that we use to screen patients are echocardiograms or echoes. These are ultrasounds of the heart and the aorta that can also measure the aorta and tell us if it's enlarged. And they can also look for what I mentioned previously was bicuspid aortic valves or valves with 2 leaflets instead of 3 that are known risk factors for dissection. The best test for studying the aorta is something called a CT scan with contrast, where we do a similar imaging to a calcium score, but we inject a dye into the veins. And that gives us a really accurate picture of the aorta to get accurate measurements for understanding the risk of dissection.
So when you heard about how Senator Graham died, did any part of your professional self think, gee, that's usually preventable for somebody with a known history of atherosclerosis and high blood pressure dating back to his 40s, which it's reported that was known? For such a privileged guy, he wasn't getting or taking advantage of the advanced preventive care that's available today? I mean, did any question like that go through your mind when you heard this news?
I don't really know the details, so I can't comment on his specific case, but generally speaking, aortic dissections, obviously there's 2 ways they can present. It can be somebody who has a known aneurysm that ostensibly has not reached a threshold to have elective surgery on, that then dissects in a sort of surprising manner when it's not very big. Or it can be somebody who has some risk factors that maybe either has not gotten aortic screening to make sure they don't have an aneurysm, or has a normal aorta that happened to be one of those unlucky people who dissects at a normal diameter. And then when a dissection happens, it depends, obviously, it's a very heterogeneous population of patients who present. But on average, the mortality of an aortic dissection, the classic teaching is 1% per hour that it's left alone. But that's on average. Some dissections are relatively low grade, and other dissections rapidly progress to rupture. So this is an average number, but basically after about a day or two, the mortality rate is 50% if it's left untreated. If people make it to the hospital and they're evaluated by a surgical team and undergo surgery, in the United States, the average mortality of a surgical operation is somewhere in the neighborhood of 10 to 15% for an aortic dissection. In more experienced hands or higher volume centers, mortality is as low as 5% or less if you can make it to the hospital and have surgery.
Yeah, and as reported, on his last day of life, he started feeling sick, but brushed off a suggestion that he seek medical attention quickly so he could go and meet the press the next day as scheduled. So you're saying that what he was experiencing was probably a sign of a failing aorta that, in your opinion, should warrant immediate attention.
Well, I don't know his symptoms exactly, but for the people listening, the symptoms that are worrisome or are classic for an aortic dissection that should make you either go to the hospital or call 911. And as a reminder, if you're going to the hospital with a concern for a dissection, you should not be driving yourself. You should be in an ambulance or somebody should be driving you. But the classic symptoms are the worst pain you've ever felt in your life. It's like a stabbing pain in the front of the chest that goes, or quote unquote, radiates to the back in between your shoulder blades. And that's the most classic symptom of a dissection. But not everybody presents that way. Not everybody reads the textbook. Other symptoms are abdominal pain that's very sharp. And then more rarely, as I mentioned before, if there's malperfusion or what's known as an inappropriate or lack of blood flow to the main organs that are supplied by the aorta, whichever organ that is that's not perfused will present in that way. So if the brain is not getting blood flow, the first symptom could be a stroke. If the legs are not getting blood flow, it may be leg weakness or severe leg pain. And if the spine isn't getting blood flow, it may even be leg paralysis. And sometimes we see people come in with severe leg pain, severe leg weakness and no other symptoms. That's a pretty rare presentation, but it can happen. But I would say the main symptom to look out for is really sharp shooting chest or abdominal pain that happens all of a sudden, and that should prompt an immediate 911 call or an immediate trip to the hospital.
Joel in Old Greenwich, Connecticut. You're on WNYC with Dr. Adham Elmously from New York Presbyterian, Columbia University, as we are trying to use the sudden death of Lindsey Graham as a teaching moment to maybe help prevent some of you or people you know from meeting the same fate. Joel, you're on WNYC. Hello.
Hello, and thank you for having me on. My quick story, and we can comment on it. Almost 7, 8 years ago, I was doing a normal physical, and the doctor during the physical said, "You have a heart murmur." And I said, "I didn't know that." And she said, "Well, I think you should go get it checked out." So she sent me to a specialist, and the specialist, after doing a echo, said, "You know, I have good news and bad news. Good news is you don't have a heart murmur. Bad news is you have an aortic aneurysm." And I said, "What is that?" And he said, "Well, it's not in a, emergency state, but I want you to then go see a surgeon that would actually do the work, but he's a specialist, and he sent me to Dr. DeLuzzo of Yale New Haven, and he was able to do a CT scan with the dye, and he said, you're beyond what the normal, like if you were in an emergency mode years ago, we would operate immediately. He said, but you're below the emergency mode, so we'll just watch it. So for 6 years, we watched it, and I did, every 6 months, I did a scan, and every about 3 months, I did a echo. And a year ago, March, well, it's been about a year, not a half, a year and a month, I did the scan in January, and March 5th, I did the operation, because he said it was too far gone. Because it would grow, and then it wouldn't grow, and it would grow, and it wouldn't grow. I always equate it to a clown balloon where I had a ascending aortic issue where it comes off the heart and goes up to the brain rather than some of what the doctor was saying. You have another aorta that goes down to the legs and the lower extremities. Had virtually no symptoms. Always very healthy, not extremely overweight, in good shape. Had annual physicals. Never had any history. Nothing in the family. Tons of cancer in the family, but nothing heart related.
How was your procedure, and how are you now?
The procedure was amazing. I was in intensive care for 3 days. I was in the hospital for 3 days in normal care. Went home, had nurses and physical therapists come to the house. It was very tough going the first couple of days. You literally learn to breathe again. You're doing very slow walks around the house, then the patio, then down the street, eventually getting up to like a 2-mile walk after a couple of weeks. You can't lift a thing, like literally nothing more than 8 pounds, they say, but you just don't want to lift anything and stress anything because it's open heart surgery. You have a zipper going down the middle of your chest. But I stayed away from sports for a whole year because I heard stories, and my doctor was good to scare me, about people that broke open their chest again, even though it's wired shut, or simply broke the stitches. And I just didn't want to have anything to do with it. So I just took a very easy year. I ate tons of protein. I am a vegetarian, so I had to find it in other ways. I'm pescatarian, actually, so I eat fish, seafood. And I just took it easy for the whole year, didn't play any sports. And then finally almost a couple months later, I started back with golf and tennis. And
That's great, Joel. Joel, thank you for sharing your story. I'm glad it sounds like you're doing well. So, Doctor, I guess that's kind of the last piece of the timeline here is when somebody does get to a point where you feel like you need to intervene, is open heart surgery the only alternative?
Yeah, so that's the fine balance and interesting part of being an aortic surgeon is you're oftentimes doing prophylactic surgery in somebody who's not really having symptoms and not having a problem. So it's not like somebody's coming in with a poor quality of life and you're improving it. They're really coming in with something that has theoretical risk, and the goal is to do surgery when that risk-benefit ratio makes sense. So obviously, the goal should be to do surgery when the risk of surgery is lower than the risk of leaving the aneurysm and having a complication. So there's a lot of thought that goes into it. Repairing every small aneurysm doesn't make sense because you're going to hurt people if you do that. Heart surgery is serious business, and there's a reason that we don't just operate on every small aneurysm. Once the aneurysm gets to a threshold where it is higher risk than the average operation, then it makes sense to do surgery. And that's around 5 to 5.5 centimeters in the average person, and smaller in patients who have first-degree relatives with dissections or patients who have connective tissue disorders. We'll operate on those patients if their aorta is 4.5 centimeters or sometimes less. So the goal of screening or understanding risk factors is to, number one, prevent aortic degeneration, but number two, if there is an aneurysm, to be very aware of it, and like the last caller mentioned, follow it thoughtfully, don't operate unless it's necessary, and then operate on the right time so the surgery is being done under controlled circumstances on our own terms rather than being done as an emergency or in a salvage situation. But the thing about aortic aneurysms are they're typically asymptomatic. They don't have symptoms. Sometimes they can, but typically not. And so that's why aortic dissections can be so devastating if we don't know that there's an aneurysm, because you have somebody walking around thinking everything's okay, and then they have a sudden life-changing event.
Well, you said near the beginning of the segment that not everybody should get screened, just people who have risk factors. With what you just said, it sounds like maybe everybody should get screened at a certain point to see if they have, the beginnings of this. Is that wrong?
Yeah, that's the common kind of the common issue that we come up with in medicine all the time is why not do this procedure for everybody, and why not get this lab test for everybody, and why not get this imaging for everybody. And the thing is, screening is not free in many ways. Number one, it stresses the healthcare system and it costs money, but it's not free in that every screening has a side effect. And sometimes there are false positives, and false positives can lead to anxiety, more imaging. They can lead to unnecessary procedures or biopsies or things like that. Most people are very low risk. We'd be screening millions and millions of patients to find an aneurysm. And so the likelihood of having a benefit when screening the entire population doesn't really add up to make sense to do it. So risk-based screening is kind of the foundation of modern medical screening. And in this case, it's the things to remember about screening are people who have risk. And the risk is a family history of an aneurysm or a dissection. So if you know anybody in your family had an aneurysm or dissection, then you should get screened. Or that can mean sudden death. Sometimes people don't really know why their grandfather or uncle died and it happened suddenly. That could have been an aneurysm or a dissection. The other thing is connective tissue disorders, so things like Marfan, Loeys-Dietz, bicuspid aortic valves. Those should instigate screening. And so those are kind of the tenets of how we approach that.
Dr. Adham Elmously, attending surgeon in the section of adult cardiac surgery at New York Presbyterian, Columbia University Irving Medical Center. Thank you so much for lending your expertise and, as I was saying, trying to use the sudden death of Senator Lindsey Graham in the context of heart disease of various kinds being the number one killer in the United States as a teaching moment to maybe help prevent some of our listeners or some of their relatives from meeting a similar fate. Thank you very, very much.
My pleasure.
WNYC's journalism and storytelling is heard by millions of passionate listeners. Sponsors of our programming gain our listeners' attention and their respect. Learn about how your organization can support WNYC and WNYC Studios at sponsorship.wnyc.org.
The United States is about to mark its 250th anniversary.
And so, on the Global Story podcast from the BBC, we're telling surprising tales of American influence on the world stage and in ordinary people's lives all across the globe.
We have this ability to export our story, and a lot of people have bought it.
I feel like the American dream is alive but not well.
From the BBC, it's the United States at 250.
Listen wherever you get your podcasts or find us on YouTube.